we're in.
Okay, good morning. I'm Isabel Fiel. I'm a graduate of this program and I have stayed on. Did 2 more fellowships after I graduated a long time ago. So this will be the beginning of my 31st year here at Mount Sinai, except for a couple. Doesn't show, right? I hope. So I went away for a couple of years to Cornell and then came back. Liver transplantation and liver diseases really sort of beckoned to me to come back. So I love this program. So it's got its ups and downs, but it's still a really great program. So I welcome all of you, especially to the first years and the new fellows. I have Camilla here, our liver pathology fellow. So any problems regarding liver pathology, go to her first. So my topic for today is autoimmune diseases and cholestatic liver diseases. Just a brief review of the histology and gross appearance of the liver. We know of the liver as being a right lobe and a left lobe, and then there's a caudate lobe and an old term called quadrate lobe, which doesn't really exist in reality. So we're only concerned about these 2 lobes, but we're more concerned about the segments, the segmental anatomy of the liver, of which there are 8. So here we have the left and the right lobes. Here, the left is composed of segments 1, 2, 3, and 4, the caudate lobe being segment 1. Segment 2 and 3 is called the left lateral segment, which mistakenly is assumed to be the left lobe. But that's only a portion of the left lobe because the left lobe consists of segments 1 in the back here, 2, 3, and 4. The biggest segment in the liver is segment 4. And the right lobe is composed of 5, 6, 7, and 8. The liver is a very lucky organ. It has a dual blood supply. The inflow is via the porta hepatis. Porta means door. The portal vein normally carries 60 to 70% of the blood supply into the liver, and that comes from the intestines and the spleen. And the hepatic artery carries oxygenated blood, which comprises about 30-35% of the blood supply to the liver. Of course, there should be an outflow, right? You have an inflow, you have to have an outflow. Otherwise, it will cause a lot of problems with the liver. So the venous outflow comprises the right, the middle, and the left hepatic veins, which then connect to the inferior vena cava, and blood gets back to the liver. So this is the porta hepatis. Here we have the 3 major structures, the portal vein, hepatic artery, and the bile duct. And of course, the bile duct is green over here. The common hepatic duct, which connects to the cystic duct and becomes the common bile duct. Okay. Histologically, you have the functional units we call either the lobule or the acinus. The portal tracts are what we readily recognize, but then there are other structures in the liver, the hepatic vein, hepatic venial, which is also known as a central venial. There are, of course, the hepatocytes, which are the most common cells in the liver, and the structure we call the bile canaliculi. Here are hepatocytes. These are normal hepatocytes. They are arranged in trabeculae. Here's a cartoon. And in between the trabeculae are sinusoids. So these are the spaces where blood percolates through the liver. So let's say the portal vein and the hepatic arteries are the conduits for blood going into the liver. The blood percolates through the sinusoids and exits through the terminal hepatic venial. And in reality, here the sinusoids are not as straight as what we have in this cartoon. So we have these cells. These are the endothelial cells, and then there are other cells, the Kupffer cells and the Ito cells, which I will allude to later. So going back to the functional unit, you have the classical lobule, which is composed of 5 or 6 portal tracts centered around the terminal hepatic venial. So you have the portal tracts at the periphery, blood comes in through these structures, percolates through the liver, and exits through the central veins. Whereas the acinus is composed of the portal tract. Pretend that the portal tract is in the middle of that imaginary structure, and in the portal tract you have the periportal hepatocytes, also known as zone 1, and these zone 1 hepatocytes are the ones that get the most oxygenated blood, whereas in the terminal hepatic venial, the centrilobular hepatocytes get the least oxygenated blood. Hence, the centrilobular hepatocytes or zone 3 hepatocytes are the most susceptible to ischemia. And not only that, the cytochrome P450 enzymes are concentrated in zone 3, and that also makes the centrilobular zone susceptible to injury. So a close-up of a medium-sized portal tract, this is not to be overcalled fibrosis, because the portal tracts per se should have some collagen, it should have some structure. This cannot be overcalled as a fibrotic portal tract. So we have the triad, we have the artery, the bile duct, and the portal vein, and you have this stroma that props up all these three structures. So these are the mainstay of the portal tract. So the triad, bile duct, and artery, and the portal vein. I call these the fraternal twins. I'm sure you know, the more senior residents have heard me say this, but why fraternal twins? Because they're similar, more or less in size. The direction is the same, and they're adjacent to each other. And of course, the bile duct or the biliary tree is supplied by the hepatic arteries via the biliary plexus. So if you cut off the blood supply to the biliary tree by ligating the hepatic artery, for example, the biliary tree gets compromised, undergoes ischemia and even necrosis that then wreaks havoc in the liver, and the result would be a biliary cirrhosis. And the portal vein is the big sister that carries 2/3 of the blood into the liver. So you have the place of hepatocytes arranged in trabeculae or cords, and around, this is a smaller portal tract. Again, we have the bile duct, the artery, and the portal vein. Around the portal tract, you have the first row of hepatocytes called the limiting plate. So these are the hepatocytes that abut the portal tract. And in addition, you have the vascular sinusoids. We already pointed out here, we see very, very slim sinusoidal spaces. And in addition to the endothelial cells, which are specialized endothelial cells because they're fenestrated to allow metabolites and other elements to circulate and go into the hepatocytes and out of the hepatocytes, hence they're fenestrated. The other component of the endothelium, of the sinusoidal lining cells, are Kupffer cells, which are specialized phagocytes. And finally, the hepatic stellate cells, which when activated lay down collagen. So this used to be called ITO cells, ITO, and lately they have been called hepatic stellate cells, and they undergo a myofibroblastic change in morphology when they're activated. So, case 1, 24-year-old woman who presented with jaundice. Viral serological markers are negative, and autoimmune markers, specifically ANA, was elevated at a titer of 1 to 160. The immunoglobulin G component was also elevated, and a liver biopsy was performed. And this liver biopsy is diagnostic. This is a portal tract, quite different from the normal portal tract that I showed you earlier. Why? Because this is filled with inflammatory cells, specifically lymphocytes and plasma cells. And notice that the edge of this portal tract is way beyond the confines of that normal portal area that I showed you earlier. Not only because it's fibrotic, perhaps, but also there's spillage of inflammatory cells into the limiting plate and beyond. What is that called? That's interface hepatitis. So here, the entire circumference of this portal tract is eroded due to interface activity. And notice that the inflammatory cells are predominantly plasma cells. And this is the centrilobular area, also showing some inflammatory infiltrate, predominantly of the plasmacellular component. And the lobule is also quite busy. We describe this as lobular disarray. So this diagnosis of autoimmune hepatitis is straightforward. You have autoimmune markers that are positive, the immunoglobulin G is elevated, and the liver biopsy is diagnostic. So we have a diagnosis of autoimmune hepatitis. It's a progressive immune-mediated inflammatory liver disease. There are no disease-specific clinical or histological features, but the histological findings are important components. We do have to exclude other similar disorders. And the primary differential diagnosis in cases of autoimmune hepatitis is drug-induced liver injury, which can have similar type inflammatory infiltrate and also histology like interface hepatitis and portal inflammation. In 1993, an international group called the IAHG came up with a clinical and histological scoring system. They revised this to become easier to follow in 1999. And finally, in 2008, they came up with a simplified version of the scoring system for autoimmune hepatitis. Depending on the score, there is a definite number. I won't bore you with that. Probable and inconclusive. So the lower the score, the less likely it is to be an autoimmune hepatitis. So autoimmune hepatitis affects both genders, all ethnicities, and all ages, but it's more frequent in females with a male to female ratio of 1 is to about 4. It's more common in North American and Northern Europeans than among Asian patients. And there's a variable clinical presentation. It's frequently insidious and patients are asymptomatic. To the other end of the spectrum where a patient may have jaundice and severe hepatitic type picture. So 34 to 35% are asymptomatic, but some non-specific complaints of fatigue, arthralgias, and flu-like symptoms. Jaundice may present in both advanced chronic liver disease, end-stage liver disease, or in fulminant liver failure. So this is the other end of the spectrum, from mild asymptomatic to fulminant hepatic failure. And 1/3 have cirrhosis at the time of diagnosis. And of note, these patients with autoimmune hepatitis may have extrahepatic autoimmune diseases as well, such as arthritis, thyroiditis, IBD, diabetes, vasculitis, and other connective tissue diseases. Laboratory findings, elevated transaminases, both AST and ALT. Sometimes they could go up to the thousands, but usually it's about in the 500 range. So normally for young people, it's under 20. So think about a 500 level of 500 IU AST and ALT. The serum IgG concentration is also elevated. There are detectable autoantibodies as shown by this case. ANA was positive in our patient. You can also see elevation of the anti-smooth muscle antibodies, other autoantibodies such as anti-liver, kidney microsomal 1 antibody. But of note, ANA and ASMA are not organ or disease specific. They can be elevated in other autoimmune diseases as well. So one has to know that there are 2 types of autoimmune hepatitis based on the autoantibody profile. Type 1 is more common. It occurs in about 95% of autoimmune hepatitis cases. And type 2, which is the pediatric type of autoimmune hepatitis, anti-LKM1 antibody or anti-liver cytosol type autoantibody is positive. The presentation is at an earlier stage, almost exclusively in female children and in adolescents. Hence, this is called the pediatric type of autoimmune hepatitis. Histology. Liver biopsy is essential in this entity. It's essential for diagnosis, for therapeutic guidance. For example, you have a patient with a diagnosis of AIH. 1 year or 2 years later, a repeat biopsy should be performed in order to determine if the patient is responsive to therapy. And also, you have to exclude concurrent forms of liver disease or an alternative diagnosis. This is a picture of a portal tract all with having the components of an autoimmune hepatitis, lymphoplasmacytic infiltrate, interface activity, but in the background you see fatty liver disease. So when we report this case, we say it's compatible with autoimmune hepatitis, but there is also an additional diagnosis that is fatty liver disease. Right? So this is just an example of why biopsy is essential in making a diagnosis of autoimmune hepatitis. Variable histology, I will show you examples of the entire spectrum. But characteristically, the presentation on liver biopsy is that of a chronic hepatitis, namely the portal inflammation and portal-based fibrosis are present mostly. So with immunosuppressive therapy, both the inflammation and the hepatocyte injury may abate or come down. So you have hepatocyte necrosis, inflammatory infiltrates in perivenular zones, prominent plasma cells, interface hepatitis, and the greater the degree of interface hepatitis, the more likely is a patient progress to cirrhosis within 5 years. So it's estimated to be 17%. And there's panlobular hepatitis. So it's not just confined to the central lobular area, not confined to the periportal area, but it's panlobular, affecting all zones in the liver lobule. You might see bridging necrosis or massive hepatic necrosis, which is associated with 82% frequency of cirrhosis and a mortality, which is almost 50% at 5 years. Cirrhosis occurs with active inflammation. That brings us back to interface hepatitis and panlobular hepatitis. I already showed you that the infiltrate is mainly lymphocytes and plasma cells, and eosinophils are sprinkled all throughout. When severe, there's bridging and confluent necrosis and some rosette formation. So there are 2 photomicrographs of prominent plasma cells. Here we see about 90% of the infiltrates composed of plasma cells, and you see spillage of inflammatory cells into the limiting plate comprised of plasma cells as well. And here is a slightly lower power magnification, again showing a predominantly plasma cell infiltrate with interface activity. This is an example of confluent necrosis. So many of the lobules have now collapsed, resulting in confluence. So this is exactly what results with confluent necrosis. You see, this is a trichrome stain, which may be mistaken as a cirrhotic liver, but it should not. I go back to the H&E stain. Here we have an island of viable hepatocytes, but the rest, and here's another island of hepatocytes that are still viable, but the rest are all collapsed. This is bridging necrosis and confluent necrosis on this side. And here's an example of bridging necrosis. By definition, bridging necrosis is a row or several rows of hepatocytes that link a vascular structure to another vascular structure. So here we have a central lobular vein to another central lobular vein, and there are no viable hepatocytes here. So this is the bridge of necrotic hepatocytes. This is the same photomicrograph I showed you from our patient, where we have the central lobular area having hepatocyte necrosis and dropout with a lymphoplasmacytic infiltrate replacing the areas of dropout. So interface hepatitis is also termed interface activity, or the old term is piecemeal necrosis. It's like chewing up individual hepatocytes at the periphery of the portal tract. And this is often prominent in untreated patients and at presentation, both. So there is extension of portal inflammation beyond the limiting plate and into the adjacent lobule, where it surrounds and causes injury to the periportal hepatocytes. That's the definition of interface hepatitis. What about the grading and staging of autoimmune hepatitis? We grade the inflammation and we stage the fibrosis. We use the same staging schemes as those of chronic viral hepatitis. We have the Scheuer, Batts and Ludwig, and Metobir. When you come to liver sign out and your liver rotation, you'll learn more about this. But at this point in time, you do not have to learn this. But we have a staging scheme from 0 to 4, 4 being cirrhotic, 0 with no fibrosis. So you see the progression of the fibrosis from no fibrosis to cirrhotic liver. A potential pitfall when staging autoimmune hepatitis with areas of confluent necrosis, this is the same photomicrograph I showed you, that these fibrosepta may be mistaken for fibrocepta that surround nodules. So this is a potential pitfall. And we've seen consultation cases where a case of autoimmune hepatitis with confluent necrosis has been overstaged as cirrhotic. Why is that important? Because to label a patient as cirrhotic is almost like you're doomed to have end-stage liver disease and transplantation, otherwise you'll die. Whereas confluent necrosis may still be treated with immunosuppression. Very active and massive doses of immunosuppressive agents may still reduce the inflammatory component, and the patient may come out of it. The differential diagnosis: viral hepatitis, Hep C, Hep B, and Hep B with delta. Celiac disease, so one should note that 4% of autoimmune hepatitis may also have celiac disease. I mentioned drug-induced liver injury. More and more we're seeing a drug-induced autoimmune hepatitis. So these are the following drugs, not exclusive, but these are the more common drugs that can cause autoimmune hepatitis, like liver disease. Minocycline, very common among young women. Diclofenac, infliximab, statins, hydralazine, methyldopa, and anti-TNF alpha drugs. Other differential diagnoses are hereditary metabolic diseases such as Wilson disease, alpha-1 antitrypsin deficiency. Both of these diseases can present with chronic hepatitis. And then another differential diagnosis, sometimes we are challenged with making a difference between autoimmune hepatitis and primary biliary cholangitis. This disease, we'll discuss shortly, affects young to middle-aged women. Autoimmune markers are positive, and there may also be a dense portal infiltrate seen in PBC. What is a treatment? It's a combination of immunosuppressive therapy, comprising of prednisone or prednisolone, and azathioprine. This is a next-generation immunosuppressive agent, budesonide. Then you have the calcineurin inhibitors, cyclosporin and tacrolimus. These are used in the transplant setting, as well as mycophenolate mofetil. So immunosuppressive therapy results in symptomatic, chemical, and histologic improvement in approximately 80% of patients. It can prevent or reverse fibrosis, and it improves the 5-year survival from 40% to greater than 90%. So it's essential that the diagnosis of autoimmune hepatitis be made appropriately. And in the clinic, the hepatologist follows the liver tests and will do a biopsy at a predetermined time. In decompensated patients due to acute liver failure or decompensated cirrhosis, there's no other way but to give a transplant. Any questions? So we go on to case number 2, 48-year-old female with a chief complaint of severe itching. Alkaline phosphatase is 860 IU per liter, and the AMA is positive. Here's a biopsy. This is a duct-destructive cholangitis. The bile duct is supposed to be over here, and yet you do not really identify it very well, but rather you have histiocytes surrounding the bile duct. This is called a florid duct lesion. By definition, this is of course a primary biliary cholangitis case. The old term for this is primary biliary cirrhosis, which is a wrong term because you don't see cirrhosis in the earlier stages. So for many decades, primary biliary cirrhosis was the term applied even in the early stage in these middle-aged women. So by definition, it's a chronic, non-suppurative, destructive cholangitis. It's a chronic, progressive, intrahepatic bile duct disease that is immune-mediated, but even up to now, the cause is unknown. They have implicated certain bacteria, certain viruses, but nothing definite still. The incidence, we have middle-aged women affected mainly, with the peak being the 5th decade. Female to male ratio from 9 to 14 is to 1 male. More common in those with a family history of PBC or other autoimmune disorders, with a prevalence of 5% amongst first-degree relatives. It can affect all ethnic groups, but the incidence is higher in United States and Northern Europeans, and low in Africans and among Indian populations. As in this patient, the presentation was pruritus and fatigue. So these are the two most common clinical manifestations. They also may have hyperlipidemia and hypercholesterolemia, and they develop xanthelasmas. These are like subcutaneous deposits of lipid-laden macrophages. Primarily, at least in the past, these patients will have xanthelasmas underneath the eye. And that was quite diagnostic, but we no longer see that because the diagnosis of PBC is made much earlier, before that develops. Hepatomegaly in 50%. So when a patient is examined, the clinician will be able to palpate the edge of the liver beyond the subphrenic subcostal angle. And it's associated with other autoimmune diseases, Sjogren, CREST, scleroderma, and autoimmune thyroiditis. And jaundice and splenomegaly may occur late in the disease. The splenomegaly is primarily because of portal hypertension. The jaundice is because of bile duct loss. Okay, so that's late in the disease. Serologic hallmark, AMA is positive in more than 95% of patients, particularly the AMA of the M2 subtype. There are about 9 AMA subtypes, and only the M2 subtype is specific for PBC. This is an autoantibody directed against the pyruvate dehydrogenase complex, or the E2 subunit. And of note, the ANA may be present in 30% of patients with PBC. That's why that may pose some difficulty in differentiating between autoimmune hepatitis and PBC, because ANA is present. Smooth muscle antibodies may also occur in up to 2/3 of patients, but immunoglobulin M is elevated instead of immunoglobulin G, as opposed to autoimmune hepatitis. In patients with PBC, the alkaline phosphatase and GGT, both are biliary enzymes, are elevated, and eventually the bilirubin may go up because of poor mobilization of bile from the liver. So it's an autoimmune disease. The target antigen is the pyruvate dehydrogenase complex on bile duct epithelial cells. There is cross-reactivity with PDC-E2 in mitochondria and microbial proteins. Hence, there's the implication that some microbes may be associated with the development of PBC. And also, one should note that PDC-E2 reactive T cells are present in not just in the liver, but also in the peripheral blood, portal lymph nodes in patients with PBC. So these are very diagnostic. Histologically, it's a non-suppurative cholangitis with bile duct injury, and also on a liver biopsy, there's heterogeneous distribution in the liver. So you may have a totally normal portal tract, and then right next to that portal tract is a portal tract with a Florid duct lesion. And this affects interlobular bile ducts measuring less than 100 microns in diameter, as opposed to PSC, which we will discuss shortly, where the bile ducts are larger. There are stages. Again, we do not have to go in depth into this, but Florid duct lesions are found mostly in the primary stage, stage 1, but they can also be found in stage 4. So just because there's a Florid duct lesion doesn't mean that it's only stage 1, because Florid duct lesions, that duct destructive granulomatous inflammation around bile ducts, goes on until the liver becomes cirrhotic. So a Florid duct lesion is composed of lymphocytes and histiocytes surrounding a bile duct. This is an even more dramatic type of Florid duct lesion. This is the bile duct. I'm outlining the bile duct, but it's lost its shape. The shape should be round or oval, but here you see, because of the basement membrane becoming destroyed here, basement membrane injury, that basement membrane that acts as a structure that confines the liver into a round structure is lost. So the bile duct becomes ectatic and undergoes a misshapen morphology such as this. And note that there's also this dense inflammatory infiltrate surrounding the portal tract, surrounding the bile duct, and also occupying the entire bile duct. You may see granulomas. Here's the artery. The granuloma is actually chewing up the bile duct. So remember the bile duct and artery going together. Here the bile duct is no longer apparent because there's this histiocytic granulomatous type of inflammation around the bile duct. And here is another example of a floor duct lesion. Again, you see this very dense inflammatory infiltrate surrounding the bile duct, and the bile duct has undergone a misshapen morphology. There are also portal infiltrates, such as what we have here, and even interface activity. But this is now a case where it's very difficult to differentiate from autoimmune hepatitis. But when you have bile duct loss and ductopenia, ductopenia by definition means greater than 50% bile ducts missing in the portal tract. That occurs with disease progression. This is a cytokeratin 7 stain. It highlights bile ductules, but the bile duct in the middle, which normally should be there, is already gone. So when the bile ducts disappear, the hepatocytes around the portal tract, the zone 1 hepatocytes, undergo this metaplastic change by acquiring a biliary phenotype. See, these are hepatocytes. These are not bile ducts. So they have undergone a metaplastic change. Copper stain may be positive. Here's a rhodonine stain for copper, and these appear as red granules. So copper is not just positive in Wilson disease, but it's positive in cholestatic liver diseases. So with both CK7 highlighting the metaplastic hepatocytes and copper deposition, that these findings confirm the diagnosis of PBC and distinguish the disease from autoimmune hepatitis. So here we have cholestasis. This is now moving towards the end stage. You have an artery here, no accompanying bile duct. So if this occurs in greater than 50% of portal tracts, this is called ductopenia. We have fibrosis with portal fibrosis. That's the beginning of the chronic stage, and portal to portal septa, and finally a cirrhotic stage. And typically with PBC, it's micronodular. Then cirrhotic nodules are not round, but they are sort of elongated with a jigsaw puzzle appearance. And the halo effect, which is due to collate stasis. Here you see the halo effect, which is typical for biliary cirrhosis, not just for PBC. And the end stage, of course, is a very cholestatic liver, a shrunken liver with micronodular cirrhosis. The differential diagnosis is a mechanical large duct obstruction, PSC, but PSC has a greater degree of ductular reaction and less portal inflammatory infiltrate. An adverse drug reaction, particularly estrogens and androgenic steroids, can give rise to a cholestatic picture. Other drugs such as phenothiazines, antibiotics, anticonvulsants can give rise again to a cholestatic picture. Differential diagnosis of autoimmune hepatitis, viral hepatitis, and other types of granulomatous inflammation such as sarcoidosis. Treatment, the course of the PBC goes from 15 to 20 years before it gets to end stage. When at the end stage, you have progression to portal hypertension and liver failure occurring in 10 to 20% in portal hypertension, and liver failure in 25% in patients that are symptomatic. But if they are asymptomatic, fewer than 5% of patients progress to portal hypertension and liver failure. So the only approved medical therapy of PBC is ursodeoxycholic acid. So this is the same treatment as PSC, which we'll discuss shortly. Any questions at PBC?
Sorry, I have a question. For this fluoride ductal lesion, we have to have this ductal destruction.
Yes. So the question is whether a fluoride duct lesion involves duct destruction. That's basically the definition of a fluoride duct lesion. So the bile duct is surrounded by inflammatory cells, and you have intraepithelial lymphocytes, you have basement membrane destruction, you have the histiocytes and lymphocytes surrounding that bile duct. Case 3, 43-year-old physician with IBD, specifically a UC, with abnormal liver enzymes and an abnormal ERCP. This is actually a physician who graduated from this medical school. And because of his history of IBD, his liver enzymes are followed every 6 months. That's the protocol, 6-month intervals. And at the point where the liver enzymes became elevated, they perform an ERCP, which is an endoscopic retrograde cholangiopancreatography. And a biopsy was done, and here you see a bile duct with this onion skin fibrosis and fibroinflammatory lesion around this bile duct. So this is the trichrome stain, this is the H&E stain, and you also see an inflammatory infiltrate right at the periphery of this damaged bile duct. This is his ERCP. This is the one that goes into the esophagus and injects contrast into the biliary tree. Here we see the biliary tree as having alternating dilatation where the contrast is located and stricturing. Dilatation and stricturing. So the term beading appearance is applied to this. So the definition of PSC is that of a chronic fibrosing and inflammatory process involving a portion of extra and or intrahepatic bile ducts, resulting in obliteration of the bile ducts and eventually in biliary cirrhosis. Affects mostly males, can occur at any age, including at infancy and childhood. The youngest reported patient with PSC was 2 years of age. But the typical presentation is the 4th and 5th decades of life. But from experience, this is not what happens. We have 20, 25-year-olds with IBD who have PSC. They can be diagnosed earlier, again, because we are a big IBD center here and we are a big liver transplant center. Our hepatologists are really keen and our gastroenterologists are really keen in diagnosing PSC earlier than in other hospitals who don't specialize as much. But be that as it may, we are seeing more and more patients with PSC at an earlier presentation. So for purposes of tests or whatever, you have 4th to 5th decades is what's written in books and in the literature, but it can occur earlier. It's more common among Caucasians and Northern Europeans than in Southern Europeans, Asians, and Africans, and the incidence is estimated to be 1 in 100,000 in Caucasians and US and Northern Europeans, then in Southern Europeans and Asians, which is estimated to be less than 0.1 per 100,000. Again, similar to PBC, the clinical manifestation may be non-specific of fatigue. But once there's jaundice and pruritus, you sort of are pointed towards PSC or a liver disease. Signs of infection may also be the presenting sign because of superimposed bacterial cholangitis. And I had alluded to this, PSC is actually discovered during the workup in patients with IBD. And of note, PSC patients have an increased risk of cholelithiasis. In fact, a patient who's 20 years old and who has to undergo a cholecystectomy because of cholelithiasis may be discovered as having PSC because patients do not have cholelithiasis at that early an age. Mostly cholelithiasis occurs in the 4th, 5th, or 6th decades. Laboratory findings, you have increased levels of serum alkaline phosphatase and GGT. Again, biliary enzymes are elevated more than the hepatic enzymes, ALT and AST. Alkaline phosphatase is typically more than 3 times the upper limit of normal. And serum bilirubin may vary depending on the stage. IgM is not raised as opposed to PBC. And there are associated autoantibodies, although these are not specific. In particular, researchers have been going a deeper dive into P-ANCA, but the results are not conclusive. ANA and ASMA and anticardiolipin and rheumatoid factor antibodies are also elevated, but the bottom line is that these autoantibodies have a limited role in the diagnosis, management, and prognosis. The gold standard for diagnosis is by cholangiography, either ERCP or MRCP, although ERCP is more diagnostic. This is an MRCP, this is from an old case, showing the beading appearance of the biliary tree. And also it's described not only beading, but the pruned tree-like appearance. Let's see. Gross pathology. This is one of the cases of an explant where you see the liver to be so distorted. Unlike PBC, where the liver, even if it's cirrhotic, it retains the shape, but in PSC cirrhotic livers, the shape is so distorted because there are segmental or lobal atrophy and hypertrophy. This results from bile duct obstruction and phlebitis. And there's also vascular impairment. So with phlebitis, you can have vascular compromise, leading to hypertrophy in those areas that are well perfused and atrophy in the areas where there's less blood supply. So hence we have the caudate lobe here being abnormally enlarged, and here you see a cirrhotic liver, some nodules that are much bigger, and some nodules that are smaller. And this is even more dramatic. Here the caudate lobe occupies most of the liver parenchyma and probably is the one that's supporting the entire metabolic demands in this patient. This is the hypertrophy, the segment 4 lobe also, that's segment 2. So the bottom line is that only PSC, if you see an explanted liver specimen having this distorted shape, think of PSC. So on histology, you may see bile sludge, stones, and bile infarcts. Here is a bile duct that is totally destroyed by cholelithiasis or hepatolithiasis. Here's the artery that goes with this bile duct. Here you have a destroyed bile duct, and you have this inflammatory infiltrate around. So fibrosing cholangitis of bile ducts is the original disease process, and it becomes progressive, leading to atrophy of the bile duct epithelium and finally obliteration of the lumen. So here again is an example of onion skin fibrosis. It's concentric around this bile duct that then leads to narrowing of the bile duct. And with progression, the patient manifests with cholestatic liver disease and finally biliary cirrhosis. So here we have the artery. So the original bile duct would have been the same size, but now we have 1/20th of the original size, and you see this concentric fibrosis. Here is a trichrome stain. This is a bile duct, which is 1/3 the size of this artery. Again, with onion skin fibrosis, and finally bile duct that has totally disappeared and is now replaced by a nodular bile duct scar. So this is on a liver biopsy. On an explant, you see biliary type cirrhosis. Here's a trichrome stain with a jigsaw puzzle appearance. Again, typical for biliary cirrhosis, where you see the halo effect. And you have fibrous tissue intervening between the cirrhotic nodules, which is paucicellular, very little inflammation. On close-up view of an H&E stain, you see these nodular bile duct scars. So this is diagnostic for PSC. Another gross pathology, you see a left lateral segment. Again, segment 2 and 3 comprise the left lateral segment. This has sort of overtaken the entire liver, and the right lobe is relatively smaller. And across the cut surface is very cholestatic. And close-up view of the porta hepatis, you can see some stasis. This is bile inside a dilated bile duct, alternating with a strictured area deeper down. And this is a caudate lobe here. So we are looking at the undersurface of the liver. And on examination of the porta hepatis, the bile duct, the hepatic duct, is inflamed, and you see this dense inflammatory infiltrate surrounding this bile duct. Very important that we sample the porta hepatis appropriately, because in about 30% you will see dysplasia. In this case, this is a low-grade dysplasia. So this is really generous sampling of the hilar structure of particularly of the common hepatic duct and common bile duct. So the stages in PSC, early stage, of course, is limited to portal tracts. Here you see a bile duct that is longitudinally sectioned. You already start to see some slight dilatation. You do see portal inflammation. There may be some ductular reaction with, when it progresses to 2, bridging fibrosis, and finally cirrhotic liver. Differential diagnosis is PBC, may be difficult on liver biopsy, autoimmune hepatitis, and this is very important, IgG4-related sclerosing cholangitis. In patients with IgG4-related sclerosing cholangitis, the serum levels of IgG4 is elevated. On biopsy, you'll see IgG4 positive plasma cells, and very important again to make this diagnosis is the fact that these patients are steroid responsive. In many instances, a patient may be misdiagnosed as having a cholangiocarcinoma because of mass lesion in the liver, and it can present on imaging studies as a tumor. But a biopsy will reveal an IgG4 related cholangitis, and that's a very good news for the patient. Another differential diagnosis is secondary sclerosing cholangitis. Treatment is ursodeoxycholic acid, liver transplantation in those patients at end stage. This is a progressive clinical course ending up in biliary cirrhosis. So the median time from diagnosis to death or transplantation is approximately 8 years, unless there's some intervention like urso. The severity of the PSC does not correlate with the severity of the associated IBD. This is a very important pearl. Complications are bacterial cholangitis, abscess formation, biliary duct stones, and cholangiocarcinoma. So remember what I mentioned about adequate sampling of the bile duct in the hilum, the reason being that there may be some cholangiocarcinoma hiding in there. And that's very important for the patient because these cholangiocarcinomas may not be diagnosed prior to transplant. So when you're examining an explanted liver, sample it and look at the bile ducts near the hilum because that's where you'll find a cholangiocarcinoma. So the prevalence is 7 to 13%, but in University of Pittsburgh, when they were sampling the porta hepatis in every single PSC patient back when they first started, they found cholangiocarcinoma in about 30% of PSC patients. So it's higher than the prevalence that's now reported in the literature. How about secondary sclerosing cholangitis? A possible etiology is recognized: ischemia, infection. So these infectious agents are mostly Cryptosporidium, CMV, Microsporidium. Some tumors can give rise to a secondary sclerosing cholangitis, Langerhans cell histiocytosis, systemic mastocytosis, and other malignant tumors. Mechanical obstruction, the most common of which is cholelithiasis. So the gallbladder will harbor all these choleliths, but with pumping, some of these smaller stones in particular can go up the biliary tree and can obstruct the common hepatic duct or one of the 2 main hepatic ducts. Trauma, radiation injury, and ruptured hydatid cysts. Also, one common cause of secondary or acquired sclerosing cholangitis is ligation of the hepatic artery by accident during cholecystectomy, laparoscopic cholecystectomy, because they only have these 2 areas, a very limited site, and they may mistake the cystic duct for hepatic artery, or the hepatic artery for cystic duct. Yeah, the hepatic artery, so they could ligate. So what happens to the biliary tree when you have a ligated hepatic artery? Necrosis, ischemia, and biliary cirrhosis. So that's what we call secondary biliary cirrhosis.
Yeah, quick question with the obstruction. So does the liver fluke, like the Asian liver fluke, does that lead to secondary sclerosing cholangitis?
That could, yes, it could.
Okay, because that would be like small.
Yes, absolutely. Yeah, it can. So the liver fluke can also lead to secondary sclerosing cholangitis. So pathologically, you'll see this is a case of a secondary sclerosing cholangitis. Here you have hepatolithiasis. It's destroying the biliary tree, causing these bile infarcts, and stones are residing within these cavities. Yellow-green pigmentation of the liver, and of course the liver is hard because it's cirrhotic. The microscopic picture would be that of biliary cirrhosis, namely there's a jigsaw puzzle pattern. There are also small and large bile ducts that are distended with inspissated bile, and there's extensive proliferation of bile ductules and edema and feathery degeneration of hepatocytes. I'm not going to go into this feathery degeneration of hepatocytes, but this picture here is that of a patient with an acute bile duct obstruction. This is chronic because it's already got biliary cirrhosis. This is acute. You see edema of the portal tract. You see ductular reaction at the periphery. The bile ducts are destroyed or damaged. And this is a close-up view of a larger duct with this inflammatory infiltrate surrounding it. You still see edema. You see inflammation. The bile duct over here is very unhappy. You see an abnormal shape of the bile duct, and you may even see periductal onion skin fibrosis. So onion skin fibrosis is not specific for PSC because you also see it in secondary sclerosing cholangitis. Okay? Just examples of secondary sclerosing cholangitis due to intrahepatic lithiasis. The shape is abnormal. You may have atrophy of the left lateral segment and hypertrophy, compensatory hypertrophy of the other segment. Here you see the caudate lobe is also hypertrophy. But this is what happens when you have vascular compromise, a secondary phenomenon due to sclerosing cholangitis. Because remember, the term is ménage à foie. The bile duct and the artery are always together. So if you're damaging one of the components, where, for example, there's this peribiliary type of inflammation, the adjacent hepatic artery can also be affected. And even the portal vein, the big sister, can also be affected by the inflammatory process. So mechanical large bile duct obstruction, these patients are of course AMA negative. The portal tracts show edema. There's a variable degree of ductular reaction, and cholestasis is present, which is mainly centrilobular in location, or zone 3. So another example of acute bile duct obstruction, edema of the portal tract, ductular reaction at the periphery. Where do bile ductules come from? These are not bile ducts, okay? Where do bile ductules come from? Anybody know? Huh? Progenitor cells, right? So they come, yeah, Joyce. The bile ductules mainly come from progenitor cells. Many people also believe that bile ductules may originate from metaplasia of the bile ducts, but basically these bile ductules are not normal are not normally found in unaffected normal livers. They only arise, they only develop when there's damage to the liver, and they're more extensive in biliary tree type injury, such as an acute bile duct obstruction. Another example of an acute cholangitis, this time you're able to see neutrophils inside the lumen of these bile ducts with periductal onion skin fibrosis. Secondary biliary cirrhosis develops due to the prolonged obstruction of the extrahepatic biliary tree from gallstones, which is the most common, malignancies of the biliary tree or the pancreas, strictures. Secondary biliary cirrhosis occurs in patients with extrahepatic biliary atresia, cystic fibrosis, and choledochal cysts. There may also be a risk for the development of ascending cholangitis due to enteric coliforms and enterococci. And this is just an example of secondary biliary cirrhosis due to hepatolithiasis. Here you see large nodules, smaller nodules, very cholestatic gross picture. And then fibrocystic disease are a group of conditions characterized by intrahepatic bile duct dilatation, such as this. And this is due to an arrested development of the embryologic ductal plate. There's a spectrum, polycystic liver, all the way to Caroli's disease, and also von Meinberg complexes. So this is a case of a ductal plate malformation where you see remnants of the ductal plate at the periphery. It's like the bile ducts have have failed to mobilize into the center of the portal tract. This is the normal native bile duct, and you have the artery, and you have these abnormal structures at the periphery. Just a cross section of a liver explanted due to a ductal plate malformation, polycystic liver disease. Von Meinberg complexes, we see this more frequently, even in normal livers. These are dilated ducts with very bland cytology. The epithelium that lines it may be flattened or cuboidal, but they are more numerous in patients with fibrocystic disease. They are usually found below the liver capsule as tiny white spots. And beware, this is my take-home message for you guys. When you go out there, you're asked to come in the middle of the night to do a frozen section because the surgeon, during a surgery for a trauma patient, saw numerous whitish spots on the capsule of the liver, and he thinks that it's metastatic liver disease. And you may mistake those as an adenocarcinoma. Okay, because that's how they look like. They're glands. They look benign, but that's a pitfall when you perform a frozen section in these patients, especially when they call you in the middle of the night. It's really more challenging. And the polycystic liver and kidney disease. So here we see liver that is huge. This could weigh as much as 30 pounds. I think we just recently got a liver and a kidney with cystically dilated, cystic dilatation of the bile ducts. Here, this is a relatively uninvolved portion. Here you can see normal appearing liver, but you have innumerable cysts within the liver and the kidney. You can have a autosomal dominant polycystic kidney disease and an autosomal dominant polycystic liver disease. And the complications can result from the compression of vital structures. Actually, these patients are so behind in nutrition because the liver is so big, it's practically occupying the entire abdomen, and they're unable to swallow because the stomach is so compressed. It's a benign process, but it has a lot of mechanical effects. And finally, you have Caroli disease. It's a congenital, non-obstructive, multifocal segmental dilatation of intrahepatic bile ducts here. If associated with congenital hepatic fibrosis, it's referred to as Caroli's syndrome. This Caroli's syndrome can present with portal hypertension, and this is one of the unknown cases today. That's why I really have to cover it. This is not a cirrhotic liver, although many people may mistake it as such, but you'll see these islands of dense fibrosis inside the liver, and that's the end of my talk. It's 2 minutes before 9. Thank you so much.
You're going through the.
I can't go because I'm having a sign off. I'm really excused myself for that.